Okay, great. All right. So before we go on and I go to disclosures, so just a little bit about myself so that you guys know my background. So I'm the assistant program director for the OBGYN residency out of West, as well as Morningside and a little bit of our coverage of BI. So we're kind of all over the city. I've been in attending for about 4 years or so. So I have a good amount of experience on this topic, which is our bread and butter. I worked with your chief resident leadership crew to make sure that we tried to keep the topic as appropriate for your level as possible. So I am going to give some big picture information, but also going to hopefully make it as applicable to your cohort. So on that note, all right, and you see the slides advancing, correct?
Yes.
Okay, awesome. So I have no disclosures to discuss. Hopefully one day I will, but just not yet. So I'll keep working on that. I want to make sure you guys know that you're welcome to ask any questions. Interrupt me whenever you feel the need. Hopefully it will flow and it'll make sense. So, if you have at the end any particular cases that you want to bring up, let us know. I'll try to work through the lecture in a timely fashion to give us a little bit of room for that. And just so that we're all on the same page, a lot of the literature still says she is pronouns that we use for my patient population, but I'm understanding the fact that that will not always be applicable to our patient populations and that we should be mindful of gender inclusivity when we're discussing and managing our patients. All right, and okay, so we're going to talk about what's normal so that we can start addressing what's abnormal. This portion of the lecture, the traditional sort of didactic, is going to be only about 15 minutes or so, just reviewing some of the basics. And then we'll go through a few cases that hopefully will be able to allow us to apply this. So first, in terms of what is normal in my world, we should know when is the average age of menarche, which is, as we know, the first period, and that's about 12 to 13 years old. That can vary a little bit based on genetics, based on some factors such as obesity. We know that patients that are obese can have an earlier onset of menarche. We know that Black patients can have an earlier onset of menarche. We don't know exactly why, but we do see that trend. A menstrual cycle is on average 28 days, but it can range anywhere from 21 to 35 days. And this is where a menstrual calendar can come in handy because patients will often tell us, oh, I get my period twice in a month. But then when you lay out their cycles, you realize it's actually, March has 31 days and seems like an eternal month. And they actually just got it in the beginning at the end. And there's actually nothing abnormal about that. The average menstrual duration is approximately 5 days, but it can range anywhere from 2 to 7 days. And then menstrual bleeding has traditionally been defined on average to be about anything less than 80 milliliters. What the heck is 80 milliliters? Who knows how to apply that in real life, but the way that most of us OBGYNs use it is to say, an average appropriate amount of bleeding is no more than soaking a pad, a large overnight sanitary napkin or a super tampon, it's changing one of those every 2 hours for about 2 to 3 days in the cycle where you have the heaviest flow. And it should really follow a sort of a pattern where there's the onset of bleeding, it can increase in severity, you have heavier flow for 2 to 3 days, and then it dissipates with complete resolution. And you should have about 3 weeks or so, depending on the length of your cycle, of no bleeding at all. And that's our standard pattern. And that'll continue on to the generally about perimenopausal stage, which is 5 to 7 years surrounding menopause. And menopause in this country on average is about 51 to 52 years old. Now, that means that by the time we're defining menopause, a patient has already gone 1 year without bleeding. So women can start having some of these menstrual changes, which can prompt their primary doctors to refer to people like me anywhere in their late 40s or so. All right. And So we're going to talk a little bit about the old terminology. And, if you're putting some of these things into EPIC, you may know that these ICP codes still exist in EPIC, but they are terminology that we're not really using anymore. So menorrhagia, which traditionally has been defined as greater than 80 milliliters of blood loss per cycle. Metrorrhagia, which is bleeding between periods. Polymenorrhea, bleeding more often than every 21 days. Or oligomenorrhea, when you're bleeding less often than 35 days. And again, those are terms that are out of favor, and you'll learn a little bit more as we go through why they're falling out of favor. So what is our term? As the title of the lecture would give away, the new terminology is abnormal uterine bleeding. And according to ACOG, which is our governing body, the American College of Obstetricians and Gynecologists, any menstrual flow outside of normal volume, normal duration, regularity, or frequency is considered abnormal uterine bleeding. So basically, any variation of what we described earlier is considered abnormal. Now, whether that's spotting or whether that's skipping periods or whether that's soaking pads and having someone who's anemic, any of that is considered abnormal uterine bleeding. So I will give a caveat, and I'll say that amenorrhea is still a term that actually does have some clinical utility, particularly primary amenorrhea. So if you have a teenager, 16, 17, who hasn't had her first period yet, and we traditionally define them as having primary amenorrhea, that's a person who you can send to PGYN or to an REI. You wouldn't be sending that person to a general gynecologist. That's a little bit outside of our purview, but that is, so amenorrhea, although it's an older term and technically is still considered abnormal uterine bleeding, is still a term that we do use, particularly in that setting. Secondary amenorrhea, pregnancy obviously is the most common version of that. And secondary amenorrhea is defined as 3 cycles, or if you've missed 3 menses, if you have regular cycles, or if you go 6 months without any bleeding, then that's considered secondary amenorrhea if you have irregular periods. Obviously, if your periods are irregular, we have to give a little bit more time to really define an abnormality or define a pathology. So this is the only instance where I think some of the older nomenclature can still weigh in, and you'll still see it in a lot of our literature. So secondary amenorrhea as a category would say is fair game to make sure to send these folks to people like me, to generalist GYNs, and we can talk a little bit more about what you can do to facilitate that visit and how you can maximize it for us just for the patient's care standpoint. All right, so when you look at the way that GYNs define abnormal uterine bleeding, we have these 3 big umbrella sort of groups, and then we start breaking it up into what are the possible diagnoses, which is what we'll talk about on the next slide. But so we have our general AUB, and then if it's a patient who's having regular monthly bleeding, but it's a very heavy bleeding, then you can designate it as AUB HMB. And then if it's someone who's having bleeding within and between cycles, then that can be AUB intermenstrual bleeding. So let's say that I would use this in the setting of if I have somebody who comes in and reports really heavy bleeding, but I don't have a diagnosis yet. On exam, I'm not sure that they have fibroids. There's nothing specific that I can pinpoint. Then I would use this in my initial stage, in my initial workup. And then once I actually have a diagnosis, then I'll go ahead and transition to more specific terminology, which is where we'll go after this. So using this extremely long term, endometriosis, definitely not something that we're using anymore. And even dysfunctional uterine bleeding, that doesn't really tell us anything. Okay, it's abnormal, but what type of bleeding are we talking about? What's the pattern of bleeding? So these terms definitely are terms we want people to stay away from. All right, so once we move from the initial stage where I said we have those first 3 categories, either just plain old AUB or AUB with heavy menstrual bleeding or AUB with intermenstrual bleeding, then once we start our investigation, we get into this category, which is what we call palm coin. Now, you don't have to obviously sit here and know all of these versions, but I did want to make sure that you had a sort of global view of what it is that as GYNs, what we're addressing, and particularly making sure to point out the things that as primary care doctors that you guys aren't missing, because that's where we can end up having delays in care and we can end up unfortunately putting patients in precarious situations, and not just primary care doctors, but we do that too. So making sure to keep our our clinical acumen on point and making sure that we try to keep these really dangerous diagnoses in mind is important. So the PALM section of this abbreviation is those are the structural causes. Those are more common. And then the COIN is the non-structural section of it. So for PALM, it's the P stands for polyp, the A stands for adenomyosis, leiomyoma is our fibroids, and then the M is malignancy or hyperplasia, which is our precancerous lesions. The COIN is the non-structural, less common section. So coagulopathies, ovulatory dysfunction, and that's a robust category. So that could include perimenopause, that could include premature ovarian insufficiency, PCOS, thyroid dysfunction, everything that it starts messing with the HPO axis is where ovulatory dysfunction falls into place. And then there's endometrial, iatrogenic, and not yet classified. Those really wouldn't be areas where you would be involved. But I think the ones I bolded in particular are things that we want to make sure we stay aware of and that we make sure we refer accordingly. All right. Oh, and my last note on the bottom was you can have multiple types of AUB. So someone can have a polyp, a fibroid, and adenomyosis that can all be wreaking havoc on their monthly cycle. So just something to keep in mind. All right, and so we have now defined what's abnormal. We have gotten a sense of maybe what's going on. Maybe it's intermenstrual bleeding, maybe it's heavy menstrual bleeding. So what do we do now? Well, just like, in medical school, although to be fair, it's been a little bit since I was in medical school, so I don't know if they're still teaching like the Socrates and the quality assessments and all of that for pain, et cetera. But you start with history, right? Anytime you have a complaint, you get your background information. So you want to qualify it just like you would qualify hypertension or diabetes. It's the same concept. I think sometimes people get nervous about qualifying bleeding or, having these personal conversations with our patients, but it would help to provide some of that intel when you refer them or when I see the patient thereafter and I'm reviewing their primary care note. It helps to focus me a little bit better. So does the patient have a prior diagnosis of fibroids or any kind of GYN pathology that I should know about? Have they had any prior surgeries or management that has failed or that went well? More importantly, what's the severity of the bleeding? How long does it take for them to saturate a pad? Are they passing large clots? Are there signs and symptoms of anemia that we need to be really concerned about? Any history of anemia, any history of blood transfusions or iron infusions, all of that can really help put into context and then help. Let's say that I do get a referral from a primary care doctor and I'm reviewing the notes. If it seems to me that something potentially dangerous is happening, I'll make sure that I expedite with my nursing team and get the patient in more quickly. But if I have that background information, it helps us to be able to triage that better. We want to ask about pain. Is there severe monthly cramping? Is there pain throughout the entire month? Do we have any involvement of GU or GI issues? Is the patient leaking urine? Is she becoming fecally incontinent? And that could tell us that there is a large pelvic mass that is either causing urinary incontinence or that's compressing the rectum. Also important for not just quality of life, but also helps us to get a sense of how severe the pathology is. And then reviewing, medications and supplements. Is the patient on anticoagulants? Did she recently get diagnosed with a VTE and now just started Coumadin? And now we need to start thinking, okay, well, this patient's going to be on medication long-term. So we need to see her more quickly. And we also need to figure out how can we manage both her VTE risk and, whatever possible sequelae can come from that, as well as her GYN conditions. Sometimes patients won't necessarily remember or won't tell us up front that they're taking birth control or that they, recently had a termination or something like that. So it's important to sometimes ask direct questions to really get the most out of your history. And then coagulopathy. heavy menstrual bleeding, particularly from menarche, and of course, your crew knows this better than anybody, but, bleeding from mucosal membranes, excessive bleeding during surgeries, even having a postpartum hemorrhage in the past, all of that increases your risk of having some kind of coagulopathy that was undiagnosed in the past. And generally our governing body, the data that we follow, is that about 20% of women who have heavy menstrual bleeding at any age could have an underlying bleeding disorder that just hasn't been diagnosed yet. And along with that, we then say it's important to discuss a family history of AUB. You don't need to go into every detail of, the sister and the cousin and the aunt's mother and the whole shebang, but getting a sense of, oh, actually, my sister did have to have multiple blood transfusions and she was diagnosed with something. Any information that you glean is going to be really critical for us. On the physical exam, obviously, you're going to be looking for signs of anemia. You're going to be looking for signs of PCOS, and we'll talk a little bit more about that. And just to put it out there, I'm a big fan of calling people out. So if people aren't offering suggestions when we get to the interactive stage, then I might start calling out names just because we're not in a room and I can't pick on you guys in person. It's of course lovingly picking on people, but nonetheless. On your physical exam, we want to make sure that we do at a very least an abdominal exam. Let's say that, there are definitely times where you can palpate that fibroid uterus up to the umbilicus or above that. And that's still fair game from a primary care perspective. And if the patient is currently bleeding, take a look at the pad. You obviously don't have to do an internal exam, but if the patient tells you that she's had a pad on for 3 hours and you look at the pad and it's not remotely stained, then that's a little bit more reassuring. Okay, and then you want to do age-appropriate labs and imaging, and we'll talk a little bit more about that. But remember that if there's any concern for coagulopathy, and I'm sure that you can teach me much better on this than I could ever teach you, but your von Willebrand disease panels, and you want to check your CBC and your coagulation studies and all that. And then we refer when necessary, whether that's general GYN, peds GYN, REI, hematology, whoever it is that needs to be involved, this is the time to get them involved. Okay, so we'll stop here for a moment. Any questions so far? Nope, okay, great. So, there are lots of folks on here. Okay, that'll make it harder to call on people, but I will do my best. All right, so case. We have a 16-year-old who presents reporting irregular periods. So what do you ask? What do you look for? What are the labs? And if one person wants to take the whole case, if you guys want to mix it up, whatever works for you. And I'm just going to pretend like I'm the patient, just give you the information or, provide it to you as you answer.
Has she already started menstruating?
Yeah, so she's reporting that she has a history of irregular periods, but sure, getting her first age or the age of menarche will be important, absolutely, sure. And let's say her menarche was 2 years ago.
Also ask if since 2 years ago, has her period been irregular? What is the cycle like, and what is the amount or how many pads would you usually have with each period?
Sure. So the periods are very heavy. They're very painful. She bleeds for 10 days and she's changing multiple pads, which is really affecting her.
How irregular are these periods? Like, what is the time span between each of the periods that she's having?
Sure. So, they do come, she feels about once a month or so, but to her, when she's talking to her mom, she feels like 10 days is just way longer than what she's hearing is normal for her. So that's why she's calling it, or she deems it to be irregular. But they are monthly. We want to ask anything, particularly in a 16-year-old.
I think I would also want to ask about sexual history, if she is sexually active.
Yeah, absolutely. Super important question. And as I'm sure you've all learned by now, there can be times when parents can be, very protective and involved. So it can be a dicey conversation. And I remind my patients who are less than 18, or any patient who brings in a relative with them, that there will always be a phase in the interview and in the exam where we're going to ask people to step out. And sometimes we, and I've seen it within my practice and my colleagues where we can make assumptions. I had a patient who lived in a facility and was very childlike. She was 16, but she behaved much younger than that. And when I asked the relative to leave, or the home health aide or the person who was with her, I don't remember who they were, the patient started asking me all kinds of questions about condoms and sex. And, there was a lot of information that we shared with that once that person left. So absolutely sexual function is important. Has not started having sex yet, has not had coitarchy yet.
I would ask for any signs or symptoms of anemia.
Mhm.
So easy fatigability, like when she exerts herself, has she been feeling more tired recently, that kind of stuff.
Yeah, so she's been feeling so tired that she's been missing a lot of school, and it's been starting to affect her grades. And that's how mom ended up finding out about it, because the school contacted mom and let her know that she was starting to have worsening grades. She just feels really tired, really weak. Ask about
And then
it.
I would ask, does she have any other signs of a bleeding, diathesis or something? Does she, when she gets a cut or a nick, does it take a long time for that to heal? Does she bruise very easily when she bumps her leg, that kind of stuff? Does she get nosebleeds?
Yeah. So she did mention that she was having more bleeding from her gums when her mom got her an electric toothbrush, because she just thought it was like a gingivitis kind of thing. So somebody put something in the chat. I will say I'm trying my best to keep track of both of them, but it will be easier if you can just speak. But I will try to get to the chat as often as I can. Okay, so yeah, those are all good questions to ask. So what are you going to look for on exam? I know, Nadim, you're the last one that's on my screen. You're going to end up getting called out again.
Oh, I knew. Okay.
Sorry.
Yeah, so I mean, obviously, I would start just generally inspect the patient overall, look at her. Does she look pale? Does she look fatigued? I would look at mucous membranes. I would look at her eyelids, that kind of stuff. I would look at her skin overall, easy bruisability, that kind of stuff. And then I would start doing more of a targeted exam. I mean, there's useful things that you can pick up everywhere, even auscultating the heart. You could see if they're tachycardic, if it sounds hyperdynamic, which it might be in cases of anemia. Does someone want to jump in?
Anybody else? Those are all very good.
Thanks.
I actually have a question about something before the exam. I don't know if this is a silly question, but is it relevant to ask if mom also has very had very heavy periods, or still having very heavy periods? Is there anything heritable about when women have, about women's menstruation? If mom is very irregular, is the daughter very regular? If mom has heavy periods, does daughter have heavy periods?
So nobody's ever, to my knowledge, there haven't been studies that have gone out to say, oh, if something is generational, that there's something hereditary about just the innate quality of bleeding. Now, pathology can be definitely inheritable, right? So we do know that fibroids run, although fibroids are exceedingly common in general populations, but there does seem to be a trend in family. Endometriosis tends to be trends in family. So I think it's particularly if you're suspecting in a young person who's having mucosal bleeding, who's having heavy menses, if you're starting to go down the path of possible coagulopathy, which is, I hope, where we realized we were going, then yes, absolutely asking about family history and any other person who could have any kind of bleeding dyscrasias would be important, yes, for sure. Okay, so
Doing an abdominal exam, we want to look for organomegaly, splenomegaly, hepatomegaly, any tenderness. That could be uterine tenderness on exam, on palpation. You want to look at the lower extremities for bruises. You want to look at the joints to make sure there's no hemarthrosis, that kind of stuff. And then I think eventually you'll make your way to probably like the public exam.
Got it.
I also want to add to that. I think Nadeem covered almost everything, but I would like to do a physical examination that is like focused on endocrine, like checking for like any thyroid, anterior neck mass, or checking for like any sort signs of like hirsutism, just to rule out like any hormonal changes as well that is going on with this patient.
For sure. So you're absolutely taking a gross look at the patient, right? And we could be here all day going through, okay, well, now let's talk about Tanner staging, and let's talk, I mean, we could be here for a while, right? With everything that we need to assess, but absolutely looking at our endocrine system and trying to see if there's anything in particular that could be triggering this aberration of our HPO axis is going to be important. PCOS for sure can be important. You know, will it present in a 16-year-old? It could. It definitely could. So I think that those are all fair questions to be able to keep in mind. Absolutely. All right. So we as an OBGYN community break up our approach into 3 sections. So, and that was based on from menarche to 18, and then we go 18 to 40, and then greater than 40. That's sort of our big picture approach to how we separate out our patients, because the sort of our most likely diagnoses, our risk stratification shifts a little bit within those age ranges. So there's a reason why I put this patient made her to be 16 years old. So in menarche to 18 years old, the most common cause of abnormal uterine bleeding is actually just what we call ovulatory dysfunction due to an immature HPO axis. So it's just, you know, the message from the pituitary to the ovaries to the uterus is just not primed. It's just not quite ready yet. So it can take 1 to 2 years for that to become a little bit more synchronized. Now, I made the case before a little bit more exaggerated. I added the mucosal membrane. So do I think that that's the cause of the bleeding of the patient that we had before? No, I don't think that it's just you know, an immature HPO axis, but that is more likely going to be your diagnosis in this age range. It usually is very mild. It usually doesn't affect their quality of life or their activities of daily living. And it's generally not pathologic. It's just something that we know can happen in those first few years. And that's something that you can prescribe if the patient really wants to have control of their cycles, to be able to have more predictability and, you know, better functioning at school and stuff like that. Then you can definitely try 1 to 2 years of combined oral contraceptives to be able to help control it. And that's not something that, you know, doesn't necessarily have to be referred to a GYN. You can go ahead and start that. And if the patient responds really well, beautiful. If she's still having irregular bleeding, then you can definitely send our way. But that would be a very fair first step, is to just prescribe a short course of combined oral contraceptives. And any sort of low dose birth control pill is totally fine. Less common causes to consider and to screen for: pregnancy, always. I trust no one, verify always. Even if patients tell me that they're not sexually active, I let them know, I hear you, but I will self-check an HCG because I have to do that. Because unfortunately, we have been burned in the past where people have not been candid with us with their sexual history. So always screen for it. And then always ask about, and I mentioned it earlier, but particularly in this age range, any kind of hormonal contraceptives or any other medications that the patient is taking and isn't really disclosing to parents. You know, pelvic infection, someone mentioned their sexual activity, which is critical. They could be having bleeding issues because of a cervicitis and an STD that they have that's been undiagnosed. So you can screen for that. Now, I'm not saying that you personally, depending on your practice, you may not be doing a full GYN exam, and that's okay. But, you know, offering the urine, gonorrhea, chlamydia, et cetera. And then as we've mentioned several times, coagulopathies, you always want to make sure that you are considering that as a possible diagnosis in the right patient. So as we mentioned, heavy menstrual bleeding since menarche, any of the, and out as a sidebar, I can send you guys this slide with some of the notes that I have for myself that I put underneath, so that can help you guys as well. And in general, our OB/GYN community says about 20% of adolescents that have abnormal uterine bleeding, and that abnormal uterine bleeding was so severe that it required hospitalization, have some kind of underlying coagulopathy. So moral of the story is coagulopathy can be very common. And then these would be people that you refer to either PGYN, regular GYN, or hematologist, depending on what the outcome is. All right, and so next patient. This is a 22-year-old who presents with irregular periods and also mentions that she's been following with derm for acne. So what do you ask? What do you look for? What do you order? What are your thoughts? Joseph Menand, what are your thoughts? Oh,
Hey, sorry, I think you called on me. I was just coming
I
back
did.
to the restroom.
I figured, that's okay. Go for it.
So I think I'd ask a lot of the same questions we were asking for the previous case. When did your cycle start? What were your cycles like before they became irregular? When was your last menstrual cycle? Tell me a little bit about how long it lasts, how many pads you use per cycle, questions like that to start.
Okay. And so I mentioned the derm for acne. What are you thinking when I mentioned that? What path am I trying to take you down? We'll stay on you for now.
Like hormonal dysregulation. So I guess like things like PCOS.
Okay, yeah, for sure. Obviously acne can be a whole lot of people, especially in our younger years, but definitely something we want to keep in mind. Does anybody want to let me know if we're thinking specifically PCOS, then what are you going to ask? What are you going to look for on exam for specifically that patient population?
So hirsutism, you're going to look for like excessive hair growth on exam. And I don't know if there are any other like signs of hyperandrogenism.
Yeah, so there's a whole slew of them. Oh, I hear somebody. Go.
Oh, don't they also get like the acanthos nigricans, like the dark spots in like the folds of like their neck and their underarms sometimes?
Yeah, they can. So let's start from the top and work our way down, because I feel like I tend to be someone who's very, the way I think through things, I try to be organized in my approach, because I feel like that helps me to remember them, right? So there was mention of hirsutism. So what, in the face specifically, what are you looking for in terms of hirsutism?
Usually check if there's any upper lip hair, also some other facial hair. We're going up, down, right?
Yeah, sure.
And also generally just looking at the patient before going up or up to downwards is to check if the patient is in the heavier side as well. Usually patients or have heavier weight could have fasting, is more prone to insulin resistance, and that it's part of the whole picture of PCOS.
Yeah, for sure. So in terms of hirsutism, they can have excessive hair on their upper lip, on their chin, on their sideburns. So you really are looking at their whole face. And with masks, it can be harder. So you might actually, and I tell patients all the time, listen, I'm going to have you just take down your mask for a minute so I can actually get a sense of what's going on. I'm also going to ask, when was the last time they shaved? Or they lasered or they waxed? They might not have it right now, but that might be because they just shaved yesterday or this morning. So asking them specifically, okay, how often, if you're shaving or waxing or whatever, how often do you feel like this is happening? How often do you feel like you need to do it? Then you're going to, they can have chest hair, they can have midline abdominal hair, they can have thick hair on arms, on legs, any of that sort of terminal hair, that thicker, more androgynous hair can happen. Now, obviously there are cultural differences that can come across the board. So we don't want to necessarily profile patients, but you just want to get a sense of what is the patient portraying that you have in front of you right now. And there are, systems in place for how to qualify hirsutism. It's the Ferriman-Galloway scale or something like that. Nobody uses it. So most of the time, just describing where you have excess hair is fine. We don't need much more than that. Okay, and then someone mentioned, generally, are they obese? Yes, PCOS patients can have a higher risk of obesity, metabolic syndrome, insulin resistance, so that's definitely important, but not all PCOS can look like that. There's also a smaller percentage of PCOS, it's somewhere in the realm of like 20 to 25% that can be normal weight and not have those other insulin resistance features. But along with the majority of PCOS patients, you can have the acanthosis nigricans for sure. So, you're looking for that velvety skin in the neck and the underarms. Those are all really important pieces of information. All right, so in this patient, she tells you that it's currently April and she's only had one period this year so far. She started her periods at 13 and they were initially regular, but now they've been spacing. And she's getting really self-conscious about her, chin hair that she has to shave every couple of days. So what labs would you order?
Go for diabetes, so like A1C, fasting glucose, testosterone is important. And yeah, I think for now that will be enough. Oh, and also CBC to check for anemia.
Sure, absolutely. And, we could be here again, just like every case that I'm giving you, we could really tease this out and spend 45 minutes and every single question we would ask. Of course, we want to always think about, sexual history and all that stuff. So one I would add to your list of tests in HCG, remember, always add that in there. But it's, what you mentioned is totally fair. So in this age range, and we'll go on to the next slide, and you can see a little more. So our most common causes in the 19 to 40 year range is going to be pregnancy, all caps. I don't generally cap, but in this I will say always screen for that. There can be, although, less likely, but you can have polyps or fibroids, and you can have that PCOS or thyroid disease, hormonal contraceptives. And then particularly as you're getting closer to the 40 age range, you want to be thinking about precancerous or cancerous cells that could be happening that would warrant referring to us. As well as the very last one is, if the patient is starting to talk about, especially this patient who was mentioning one period in April, and that's it, then we want to think about premature ovarian insufficiency, previously called premature ovarian failure, but failure has a very negative connotation that is not patient-centric, so we're moving away from that term. So in terms of labs and imaging, at a minimum, we want to do our HCG and our thyroid testing and our CBC if we're concerned for anemia. If you suspect PCOS, which one mentioned the testosterone, for sure. And if you can order any of these, all to be able to tee us up so that when we step in, we have a better sense of what's going on, that's great, but definitely not required. So a testosterone panel, and every hospital is a little bit different, with what's included in that testosterone panel. 17-hydroxyprogesterone, which is our screening test for the congenital adrenal hyperplasia, which I'm sure you guys can again tell me much more about, but that is something that is recommended because that atypical congenital adrenal hyperplasia can end up presenting as a PCOS picture later on. If the patient has extreme virilization, so if they're having voice changes, if their voice is getting deeper and they mention that to you, if they're having extreme hirsutism and hair changes, if they have really terrible acne, cystic acne that's really quite pronounced, those could be reasons that you want to check for LH, FSH, your estradiol, the DHEAS, which is particularly a very potent testosterone hormone. And this in particular comes from the adrenal glands. So when we see extreme hirsutism, extreme virilization, particularly in this age, we're thinking about a possible ovarian mass, and we're thinking adrenal masses that could be causing these abnormalities. So again, not requirements by any means, but just so that, if any part of this, if you remember and you can send it, that just puts me in a better position when the patient's in my office and I can try to help this patient more quickly. And then the last line, our governing bodies for any patient who's diagnosed with PCOS, irrespective of the phenotype, they do recommend screening for hypertension, for type 2 diabetes, for dyslipidemia, and depression particularly can be really pronounced in this population, and OSA. So Juan, you're totally right, sending out your hemoglobin A1C, your fasting, all of that is going to be super important. If she's pre-diabetic and obese and has signs of metabolic syndrome, we might want to also send out that CMP so that we can, try to start thinking about metformin and nutrition and some of those things. Okay, and then if the patient's amenorrheic, if she's gone long periods without any bleeding, then prolactin, which can cause severe dysfunctions, even at low levels to the HPO axis, can be something that can be added as well. Now, the treatment really depends on the diagnosis. You do not have to worry about that. That is something that I will take care of gladly. And it really will just depend on the picture and once the diagnosis that I end up deciding upon when I have the patient in my office. And this is somebody that we can always refer to GYN. So, don't ever feel like this is something that you have to manage independently. There are patients who have really bad PCOS and all kinds of metabolic derangements that I'm also managing them in conjunction with endocrinology, because it's just more than even I myself can handle. So it's all good for us to work together on that front. Okay, thus far, questions? No, okay, perfect. So last case, 48-year-old, BMI 48, and she presents with irregular periods. So in particular, we'll do this a little bit differently. So we'll start with, given the fact that she's 48 years old, based on what I told you before and about more likely diagnosis in patients who are 48, what are maybe some of the diagnoses that you want to try to think through, and maybe we'll work that way, just to try not be redundant.
We could be approaching her menopause.
Sure, perimenopausal for sure. So if we're thinking perimenopause, what are some of the questions you're going to ask her to try to corroborate that diagnosis?
If the timing of her periods have been like gradually spacing out more over recently, if she's having like menopausal, like hot flash symptoms.
Yeah. So some vasomotor symptoms for sure. So aside from hot flashes, what else could she be experiencing? What are some other vasomotor symptoms that your patients might report to you as their primary care doctor?
I don't know if they would experience vaginal dryness.
I don't know if I wasn't sure if that's like a vasomotor symptom.
Yeah. So vaginal dryness is part of it for sure. You could have that. So generally, we can talk about the vasomotor symptoms. We can also talk about the genital urinary syndrome of menopause, which then focuses in specifically on the vaginal symptoms. But sure, we can talk about any of these perimenopausal changes. So hot flashes for sure, vaginal dryness. What else?
Night sweats, heart palpitations.
Yeah, you can have anxiety, you can have definitely night sweats, and with night sweats can come along insomnia, where patients can have real bad sleep derangements, and they can be really debilitating for some people, and make it exceedingly difficult for them to function the next day. And I will tell you, so on a personal note, when I was first starting out, people, particularly in OBGYN, we get really nervous treating HRT or providing HRT and managing hormone replacement therapy. And there was a whole generation of folks who really didn't provide any kind of hormone replacement therapy at all. And the pendulum is swinging, and we're starting to get more comfortable. And it wasn't until my mom started going through really bad hot flashes that was keeping her up all night. And then she wasn't able to function at work, and she was starting to get in trouble at work. And I started researching more. And at that point I was in my early residency, I think, that then I ended up taking the information I learned and having a call with her family medicine provider. And together we kind of worked through it. And I really had to advocate for her. And it was through seeing my mom absolutely miserable that I realized, like, man, I really wasn't giving this the credit that it needed. And, I was much more uncomfortable than I needed to be once I actually understood the data. So much of it is just trying to make sure that we don't cause cancer, right? Like ultimately people are just terrified about anything that can cause cancer, but that risk is actually so small when it's done safely. So hot flashes, vaginal dryness can be really frustrating to people's personal lives. So those are all super important. Any other diagnoses that we want to try to make sure we think through, particularly in a patient who's 48 and has a BMI of 48?
Like an ovarian, like cancer, other malignancies.
So malignancy in general, not so much ovarian, more endometrial, more uterine for sure. So we do know that with increasing BMI, we do have excess estrogen production from all of the adipose tissue and the conversion of testosterone to estrogen, and that increases our risk of having pre-malignant, so those hyperplasias, as well as the endometrial, the uterine malignancy. So this is someone that I'm definitely going to want to see. I don't want you to have to tease out whether this patient is at high risk. I would likely have to do an endometrial biopsy, a sampling of the lining of the uterus. I'd have to really look closely at her ultrasound. If it persists, I might have to do a procedure to look inside the uterus and make sure there's nothing dangerous going on there. So definitely this is a patient that, I can make sure to tease those things out and take that risk on.
Maybe endometriosis?
Yeah, so endometriosis is a good thought. It tends to have more pain, and not so much at 48, but along with endometriosis, the thing that I would actually say may land a little higher is so adenomyosis, which is when that glandular tissue, it's kind of a cousin of endometriosis, when that glandular tissue that's supposed to be in the lining of the uterus is actually within the muscle of the uterus. The periods can get very painful, can get very heavy. And that is something that, people are now realizing is much more aligned with endometriosis than we initially thought. So yes, endometriosis, but in an indirect way. All right. Anything else?
I think just on the differential would be also like a late pregnancy and then other endocrine disorders like hypothyroidism or Cushing's or something like that, especially if the weight loss or weight gain has been pretty rapid recently.
Got it. Yeah, you're totally right. A man after my heart. Yes. Pregnancy always. It can always be that. So absolutely, we want to make sure that we assess pregnancy. And then endocrine dysfunctions generally, absolutely. We know that as women get older, we have higher rates of Hashimoto's and other kinds of autoimmune conditions that can change that can change the HPO axis. Obesity absolutely can affect your HPO axis and can cause irregularities in your cycle. So for sure, those are all possibilities. All right, so that was, let's see. I just wanted to make sure I hit on all of these topics. Sure. So we talked about the most common causes, and the first suggestion for a possible diagnosis was declining ovarian function due to perimenopause. Perfect. But we could have leiomyomas, fibroids, polyps, and then that cancer that we always want to think about and be weary of. And then labs and imaging that we would recommend for this range would be obviously HCG, thyroid, CBC, if concern for anemia. Again, as you're noticing, there is a pattern here. And then, if you want to order the pelvic ultrasound to help speed things along, totally fine. And like I said, this is always someone you can refer to us. All right. Any other questions or, cases that you guys have had, patients that have been lingering on your brains that you want to pick my brain about now? If not, that's all I have.
I have a question.
Yeah, go for it.
Can you guys hear me?
Yes, I can.
Okay. Can you see a polyp on ultrasound? Or do you have to go in and do a surgical procedure to see it?
Yeah, fair question. So if the polyp is large enough, then yes, potentially we can see it on ultrasound. So generally anything larger than about a centimeter, it would distend the lining of the uterus sufficiently where we could actually see a hyperechoic mass in the ultrasound. There also could be some other ancillary information that could corroborate it. So if there's a feeding vessel when they look on Doppler, then that can definitely help us to confirm that diagnosis. But sometimes you don't. If they're very small, sometimes you don't. So it depends a little. Mm-hmm. Good questions. Anything else? All right. Well, it was very nice chatting with you guys. If you have any other questions, you're welcome to email me. If there's a patient or a scenario that you kind of want to run through, I'll send this slideshow, like I said, over to your chiefs to be able to have that get disseminated as well. And that's all I have for you today.